This conversation. There we go. Our friend Becky that pulled us all together and connected us all is actually on a plane right now, as you might know. So she's not even here for the conversation, but just kudos to Becky for bringing folks together and really, really appreciate you all being here and your willingness to talk to us. I want to do a little bit of level setting. I think you've gotten some information from Becky around what this conversation really is. This is this group's second kind of go at the conversation. So there's already been quite a bit of conversation, but a big thing that came up in the original conversation around restraint was that we actually wanted to hear, and particularly as it relates to facilities and folks kind of on the ground, is like we need to hear directly from you. And we don't want to make a lot of assumptions. And so really appreciated Becky and Brandon kind of pushing for making sure that we have a kind of an equity of voice of different experiences and that's kind of our goal today. So I haven't met a number of you. I'm Trace with Keystone Policy Center. I do the one of the facilitators on this group, and so we typically break out into these subcommittees to kind of have deeper discussions, and then we bring it back full group around any recommendations. So this group is working through a really hefty amount of directives aimed at a variety of things of reducing youth who run from out of home placements, and so we've kind of found ourselves in this conversation around restraint and the law as it's currently written. And so really, I just want to get super clear with you all around what this group actually is looking at as the directive is written, because obviously this, if left to wonder, you could take this in a number of ways. And obviously there's a ton of conversation to be had. There's a ton of conversations that have been had. I think Stephanie made the point that, this is not the first time that we've had these conversations, and it certainly probably won't be the last. And I think you all know that as well. So there's a unique kind of angle that this group is taking, and I want to just honestly just show you the direct language from the directive that they're wrestling with. And then once we're kind of level set there, we'll do some introductions, bring you all in. I've got some pointed questions, and then really just want you all to be able to speak kind of as candidly as possible. So here is, let me get full screen here. This top part here is our, I'm going to highlight that. For some reason, it's not working. All right, so this top part in all caps is the directive that this group is really working with. And I want to highlight just the word analyze, because that's obviously different than, a number of other ways to interpret what we're actually talking here. So you all are part of this analysis, right? So analyze the comprehensiveness and effectiveness of existing state laws and regulations and placement facility, I'll let you read all that. Protocols to respond to a child's threat to run away from out of home placement and for promptly reporting, locating, evaluating, and treating children who have run away. So, is the law clear? Is it effective? Is it, do folks feel confident in their analysis, in their understanding of like what it says we can and can't do, and what are the unique challenges there? Obviously, we also put in that the use of restraint obviously is when there's been deemed an emergency, in cases of emergency, and then put in the definition of emergency here. So just wanted to like make sure that we were all on the same page as to like what is actually written, and obviously how folks interpret that is the crux of the conversation. So I'm going to stop sharing there. Jordan, anything to add as far as level setting us in the conversation before we jump into with the group?
No, I'm just adding the language in the chat that you had on that slide so you can access it as this discussion is going on.
Sweet. Okay, cool. So what I'm gonna do now is for our guests and also Brandon and Dennis who are on the panel, I'm gonna go ahead and just like spotlight y'all just because I think it'll be good for you to know who's. Oh, I'm not a. Can you make me a host, Jordan? Sorry. But would love to go ahead and just let's do some introductions. Who's all here? Who are you representing? I'm guessing you're here on because you were volunteered with Becky, but just would love to hear a little bit about you, maybe how long you've also been in your role where you are, and we'll go from there. So, Dennis, I know folks know you, but I just want to make sure that we're all, yeah. So if you could just jump in first, introduce yourself, and also just kind of your angle for this conversation, and then we'll keep it going.
I'm Dennis Desparis with the Colorado Department of Human Services. I'm usually in the intervention group, but was asked to be in this group today.
we borrowed Dennis's time. So thanks, Dennis. Dennis will bring in the very important word from CDHS and kind of help us dig into some stuff. Pam, go ahead.
Hello, all. I'm Pam Chalor from Shiloh House, and I've participated in some of these as an audience member, months ago, I think. So I started in the field in '96 as a clinician working at Shiloh with residential and day treatment kids, and ended my career at Shiloh for the first go around as chief program officer, and then went over to play at Tennyson Center for about 7 years as chief program officer there as well, and then returned to Shiloh House. In a different capacity. I'm chief liaison officer, strategic analyst, and I've been back with Shiloh since I think 2016. And both Shiloh and Tennyson, right, have a continuum of care from residential respite to day treatment and community-based services. And I've had the privilege of attending some of your meetings earlier on. And thank you for having us again to hear our updates.
Yeah, thanks, Pam. Really appreciate that. Marnie, go ahead.
Hi, I'm Marnie Lyons, and I actually am the executive director of Gateway Residential Services, which is a QRTP on the Western Slope, and also of Wimspire Child Placement Agency, providing foster care across the state. I've been with this company since '96, and in my current capacity, I'd have to really take a look at that. I think probably 20 years in the role as executive director, I would say, with Gateway Residential Services. And then with Wimspire, it's been about 4 years in that role. And so I am just really glad to be here and hope to be beneficial to the discussion.
Thanks, Marnie. '96, great year. Love that. Brandon, go ahead.
Hi, I'm Brandon Miller, Executive Director at Southern Peaks Regional Treatment Center. I've been the director since a decade now, actually. So, worked in residential since 2004 in different facilities, starting in Pennsylvania and then coming out to Colorado in 2006.
Love it. Thanks, Brandon. Appreciate you willing to jump in. Lauren, bring us home. Who are you?
Hello, yes, Lauren Campbell, and I am the Chief Operations Officer with the Griffith Centers. I have been with them for 5 years, and I've been in my current role for 2. I oversaw our residential program before that, and then I have worked primarily in residential treatment centers for the last 13 years, so in different states. So it's also interesting to see how different states operate.
Yeah. That was going to be my next question. I was like, all in Colorado? Okay, so you're bringing multi-state. I'm actually curious, Pam, Brandon, Marnie, Lauren, and actually Dennis, multi-state experience or just in Colorado? So Lauren, multi-state. Marnie?
Just Colorado.
Just Colorado. Brandon?
Multi-state.
Multi-state. And then Pam?
One year at New York City Residential Treatment Center.
Okay. And then Dennis?
Colorado.
Cool. Yeah, so interesting to have a little bit of a mix there as far as obviously Colorado's trying to do something different here with this task force. So having that experience will be really helpful. Cool. Well, really appreciate y'all. Again, I've got just a couple of level set questions, and Dennis, just a heads up, I'm gonna start with you because I think it would be really helpful, obviously, with like the CDHS perspective and kind of talking through interpretation side of things, and then really opening up to providers around, okay, and then how does this also feel on your end, and what are the challenges and unique conversations that you all have amongst each other? What does that actually look like on the ground? And then really want to open it up to the group. So I'm not going to try to point too many questions. I want our task force members that are on this subcommittee to jump in here in a little bit, but let's get a little bit of level setting around just generally speaking how we think about interpretation and what are the unique challenges for providers, and then we'll kind of get into some of the nuances from there. All right, so Dennis, I'm going to start with you. As we were thinking about different questions and I was kind of wrestling with, how are we gonna how are we gonna coalesce around a conversation and level set in a way that folks can really dig in with some meaningful questions. So, as we think about this group and the analysis that they're trying to do on the clarity or lack of clarity or however they might feel, from a CDHS perspective, I'm curious to kind of hear, what is and I know some of this you're going to be like, we've shared this, and I just want to, like, for purposes of this conversation, want to bring it all to the table. So, what is your interpretation of the laws that's currently written, in what we're talking about? Because, as the monitoring agency, and I know that there's this kind of memo that that can be referenced that can't be explicitly shared, but around definition. And so just want to like throw it to you broadly around from a CDHS perspective. What do you feel like is clear, and how do you all interpret this?
Oh, well, first, I think the first thing I'd like to dispel is in this committee, I keep hearing the word risk, and the word risk does not appear in the definition of what allows you to a restraint. We need to strip the word risk out of the discussion. It's not there. It's an imminent threat of bodily harm to self or others with the present means to carry it out. The word imminent means now, right? And threat to bodily harm to self or others seems pretty clear. So I'm not sure. I'm confused as to why there's a question about interpretation in this case. There has to be right now a threat of bodily harm to self or others in order for you to put your hands on a child or youth and restrain them. So that's always been the department's stance. It's particularly around like children and youth running from facilities. It doesn't meet the threshold of imminent bodily or threat of bodily harm to self or others unless there's other factors in place, such as like in Shiloh's Longmont facility, there's a really busy road, and the youth says, I'm going to run out in the street and run right in front of a car and have it kill me or have it run me over. Right? That would be imminent threat of bodily harm to self or others, right? Or in the Longmont facility, the youth is really dysregulated, and it's clear this youth is not making any good decisions and is running right towards the street, right? And there's cars going back and forth, and there's still an imminent threat of bodily harm to self or others, even though the youth is not particularly making the threat, so to speak. But we've had providers in the past say, well, we're surrounded by this big field, and there could be rattlesnakes out there, so we need to restrain the youth when they run. No, that's not an imminent threat, right? The rattlesnake is not right there. The youth isn't almost about to step on the rattlesnake, so to speak. So that's always been our interpretation. Well, it's not really our interpretation. It's just this, the way we've always looked at restraint when it involves runways from facilities.
So really the challenge I'm hearing is this: the word risk comes up, and you're trying to differentiate, or you all feel strongly about the differentiation between risk and imminent. Is that?
There's no risk doesn't occur. It's an imminent threat of bodily harm to self or others. And imminent means now. It doesn't mean it could happen an hour from now.
Thanks for that, Dennis. Brandon, I saw your hand shoot up, so love for you to jump in.
Yeah, I mean, I don't disagree with Dennis completely on that, but there is, countering things that make it conflicting things in Colorado that make it gray. For example, here, let me read. So, defined in Colorado case law, imminent is likely to happen without delay, impending threat. Colorado Supreme Court has equated imminent danger with imminent risk. People versus Mendoza, Balderrama, and then there is a duty to intervene through case law and health studies or in health settings. And I can read through all the case law, but like when we're talking about these situations, it's when regulation and definition of regulation don't match up with, these situations. Facilities and organizations are at risk and in danger of, have unattainable expectations, so that we're following this regulation, but then if it doesn't happen, we don't intervene, and then we're getting sued or we're getting in trouble through certain aspects of our approaches. And that's where the conflict comes about, because when you let a kid run and a kid runs and hurts themselves, and we know we admitted that kid with their likelihood to self-harm or become suicidal, even if that action is not at that moment, right? But we allow that kid to get away from us. We are in danger of accountability that might not be with regulatory providers, but operating as an organization and what we do as an organization. Am I making sense?
Yeah.
Yeah, but I want to point out, you used the in your case law quote, you used the terms imminent danger and imminent risk. Neither one of those phrases come into play here. That needs to just come out of your vernacular when it comes to restraint. It's imminent threat of bodily harm to self or others. It's nothing else other than that.
I'm not sure how it doesn't come into play. I mean, they're saying
And
case
the
law is
statute,
saying, yeah, but
the
the case
statute.
law is saying that there is an equitable understanding of between imminent risk. It does not mean necessarily that the action is not happening right there, that the likelihood of that action to occur is what you have to take into fact. And how I've interpreted it, based on what I've looked into, is that the fact that we're placing these kids with a caretaker that has to supervise them, and we know the likelihood of this behavior will occur if they are trying to create an opportunity for it to happen, just because the incident is not right in front of our eyes. The fact that we know that they're trying to run to do something, the likelihood that they're going to do something, we can't take action if they get away from us. And that's where the conflicting understanding of it and our responsibility is there. And I get that what you're saying, Dennis, is that the regulatory definition is saying no, you have to be there witnessing this imminent, but that's where the conflict comes about. We have accountability in many other aspects. I mean, if I get sued for $2 million, it doesn't matter what you cite me or however, I'm done. The organization is going to be done. Like, we're shut down. So, and we're not even talking about the moral and ethical, you know, challenges that you go through, allowing somebody to hurt themselves that are going to hurt themselves. This is a lot of the reason why we get in this business is to help people, and we don't want to you know I know a kid's going to hurt themselves if they try to get away from us. I don't want that to happen. So I think there's it's a more complex issue than just that definition that you're talking about, is what I'm saying.
Dennis, just want to give you a chance to respond if you want to. Otherwise, I'll open it up for.
It hasn't happened that a facility's been sued in Colorado for a kid running from their facility. I would argue that you're far more likely to be sued for injuring a child or youth that tries to run from your facility. I mean, that likelihood is far greater. I don't like. I mean, none of you have access to the data, but youth get injured in restraints. Is everybody kind of clear about that? That happens. Like, it's not a risk-free intervention. Staff get injured during restraints. It's not uncommon. It happens, right? So when you're looking at the definition of imminent threat to bodily self or harm to self or others, that's a good threshold, because are you going to create more harm by restraining the youth, or the youth absconds from the facility and maybe comes back an hour later? I mean, I don't know how you're making those determinations. Sorry, go ahead.
I was just going to respond that I agree with you 100%, but that's why it's situational. It can't be a black and white overall, regulatory saying that you can't do it. All right. It should be a focus on, is this situation, like, are the practices, the evidence-based practices, and and most of these restraint models, if not all of them, that's being used by people are evidence-based, and are we following the practices that tell us when it is time to intervene and appropriately? And I don't disagree with you, Dennis, at all. Like, restraint reduction and approach should be the goal of every organization and the state, but that, I don't believe you get there by eliminating, uh, these type of situations, and saying no, a blanket like cover of saying you can't do it ever on this, particular, scenario. I think you look at the practice of, of what we do in those situations and how we do it to reduce the having to use these tools. Just because the tools are available doesn't mean you should use them, and I think that's a different topic altogether.
Yeah, and Brandon, you're kind of getting at something that the group wrestled with in the last, I think you're getting at something that the group wrestled with around effectiveness of the laws that's currently written doesn't allow room for any sort of good faith clause or like professional judgment, right? Of like when those situations might be happening versus not. So if this group was interested in any sort of recommendation around that, was kind of something that we left kind of hanging in the air. That was a big question around. All
Yeah,
right, we need to
well,
continue the conversation. So I would be curious to hear from y'all on that idea of like, do you feel like the law is written in an effective way where there is professional judgment that you get to utilize or not? And what are your thoughts on that? But Brandon, you jump in, and then Pam, then Elizabeth. I was just thinking about you, so I'm glad you're raising your hand. Would love to bring you in too.
yeah, I mean, I look at it as like my own kids. I mean, if my own kid was, highly escalated and not in the right mind and rational thinking, and I'm trying to get them to uh you know not do something, run away or whatever, I'm going to stop them. And that's the purpose of the child prudent parenting, push of people, when we're in caretakers, special relationships, whatever you call it. And the very fact is that, like, I would do the same for any kid that I felt that was going to end up putting themselves in a dangerous situation. And I think that's what you want out of the caregivers in the state of Colorado. But that doesn't mean that I would just go right to that, or that's the right method to be using in every situation. It just means that if I had to do that, I would do that, and I would protect my kid, and I believe that being in charge of other people's kids is a serious thing, and I would do. It would be, I would want if my kid was in one of these facilities, like, I would want them to be approached like that as well, like that they're being protected, and they would do what they would do with their own kids in regards to trying to protect them. And that's how I look at it.
Thanks, Brandon, for sharing that. Pam, I'm going to bring you in, and then Elizabeth, I'll spotlight you and bring you into the conversation as well.
Thanks. So many thoughts. So let me just get maybe a couple 4 points out. I think, like, do we have the data of how often this is happening? And is it mixed with a narrative that there is an overuse of restraints, that there are bodily harms? And I think we need to look at that data, because that could just be a narrative out there, right? And Dennis, I understand you guys have all the CIRs and you investigate, right? And so you probably have that. How often is a restraint leading to bodily harm? But then you have to equate it with what was that bigger picture, right? And so in that imminent situation, was that bodily harm of a bruise or what have you? I hate to say this, but the lesser of the evils kind of thing. So how are we comparing apples to oranges? Are we using the right data to really dissect this issue? And Trace, you said something that Brandon, you were talking about too, but I think where the conflict is in that professional assessment, right? So we as providers are following a national curriculum, right? A national curriculum, right? These are just not kind of one-off situations of how our staff are trained to use restraint, but the first 3 of the 4 days are around preventative interventions, right? And they're trained how to use that professional use of self. None of us are in that situation on a Friday night at 6:30 during traffic, when the milieu is escalated or the kid is escalated. We're not necessarily following that staff and knowing in that moment the decision making that they have to do, right? And so they're trained and they're asked to use their professional judgment in taking care of that kid and using the de-escalation and all of that. And then what happens is, as been mentioned, is the conflict of definition of that, right? And so then we as a provider, the staff will be audited, right? We'll be investigated as to if Dennis's team, right, agreed with how that went on. And we are having conversations with Dennis's team anyway. I mean, Dennis has been very open to this, and we appreciate that, Dennis. And so there's like kind of off this subject, there's conversations around the subjectivity of interpretation when there's an audit of what kind of happened. So at what point do we define professional assessment, right? Without it being kind of picked apart. At what point are these professionals hired and trained and asked to do a job, put their lives to their on the end? And Elizabeth, I'm not minimizing what happened with you, right? But staff, if they're questioned or found guilty of doing something wrong, then there are consequences for them, right? They're on the child abuse registry and they can't be in this field. But also, I think there's also we know that restraints are not preferable, right? We know and we hear from national gurus, right, and research that it is best to not go hands on kids. We hear from Dr. Ross Green in Maine with collaborative and proactive solutions, which years ago we tried to implement at Tennyson, around really even the de-escalation is too late, right? How can we get ahead of these behaviors before it even gets to the point of needing to de-escalate a kid? And that makes sense. However, that is not just a provider duty. That intersects with how are we as a state using our continuum of care? And as you've heard, we're getting more and more acute kids in these levels of care. We're getting, for our community-based referrals, kids that we think should be in day treatment and kind of in a more specialized treatment for 6 hours a day. We're getting kids in residential who, used to be in the hospital. So everything is being kind of, the acuity of kids is going down the line in the continuum. And if it works, fantastic. But so many other things intersect with that, because to say restraints is not trauma-informed care and let's not go hands-on has to match with how we're utilizing our continuum. And we are getting kids who are very escalated, who have been in and out of placements, who are, the current cohort of kids have not fully experienced FFPSA and prevention model being used at the right time, right? We've got a cohort of kids who are 10 to 18, right? So we've got to figure out how to get them safely through the continuum before we can figure out how FFPSA can really work with the others. And so I don't know if I'm frozen. You guys are all frozen. I'll continue to talk. So I think we have to be careful that if we don't, to say we shouldn't go hands-on these kids, it's not trauma-informed. Yes, research and philosophically that makes sense, but that doesn't match with the population we're being given at that day. We could get a kid. Shiloh runs residential respite, right, which is short-term or long-term QRTP that is assessed. But these kids are coming high level, high trauma, high reactivity. We're trying to stabilize the mental health symptoms, but mental health is never going to be like, it's not cured. It's right. It's how to manage it. And to expect to fit this not hands-on to this population that hasn't truly experienced the full effort of FFPSA, because it's only been 2.5 years, is not a match. So I understand there has to be accountability of providers. I understand we don't want to restrain. And we want to do the best for kids and keep them safe, but it has to match how all the other systems are integrating with the placement of kids and the use. And so I think maybe there almost needs to be a step model, or I would suggest a slow strategic plan for Colorado, because until we're fully referring and using the continuum of care as needed and not just chasing beds or what have you, I don't know if the philosophy can change until the implementation of how we do it catches up, right? Hopefully that made sense. Thank you.
Yeah, thanks, Pam. I really appreciate you jumping in there. Elizabeth, I'm going to spotlight you, and then Brandon, I saw your hand shoot up too, so we'll come back to you. But Elizabeth, really appreciate you being willing to join this conversation as always, and yeah, would love to bring you in.
Thanks. Dennis, I just want to clarify, all due respect, you said that no case has been brought against any treatment center in Colorado. That comment is categorically untrue. So also, like Brandon said, there's a lot that goes into it. So this is the piece that we need to change, right? Is allowing providers to assess imminent danger, right, from someone who's making threats, or evaluate a kid before they go into the system, saying this child is suicidal. They've repeatedly done this behavior. If they run away from this placement, they are at imminent risk or imminent danger. I'm sorry. There's an imminent threat of danger. Okay. And so that's what we need to address, right? Is how it's written. And we need to allow providers to be able to make those assessments in the moment without the liability. Like me as a parent, I'm fully prepared to sign over a liability waiver because I expect these providers, as Brandon said, to treat this child like they're their own kid, right? And to make those decisions. And then obviously we need more training for the provider, for the people on the ground in the milieu, right? They need to be more trained. They need to have the skills to make those assessments. That's going to mean higher pay. Obviously, it's going to mean more funding. I don't know how all that piece works, but something has to happen. And, you know, it can't just be as black and white as you presented, Dennis. Thank you.
Elizabeth, appreciate your comments. The two things I'm pulling out from what you're sharing are the training component, right? A call for, and I'm kind of curious from providers to hear, and maybe Elizabeth also, you can ping kind of like your experience as a parent too, but I'm guessing that's like a consistency thing, that's a effectiveness, you know, what are the unique challenges around the training as it currently is? And then the second piece is this professional judgment, this, you know, is the law clear in the way that, again, from a parent's perspective, that you would hope that folks could utilize professional judgment in those situations because you've seen, you know, you want them to feel like they have the room to do that. Am I interpreting that right? As far as I'm just trying to get clear on,
Yes. Yeah.
Yeah.
I mean, I want the providers to be able to make those judgments and to be able to use restraints if necessary. Like with a child who's repeatedly said they're suicidal, they've repeatedly gone into the street and laid in the road or done other types of self-harm. You know, to me, that's imminent danger if that child is running away from their placement and they're 12 years old. You know what I'm saying? That's imminent danger. It doesn't matter, like they're gonna go self-harm. Like Brandon said, they have a history of self-harming, you know, so they're gonna create that situation. That's what they're trying to do, is go create a situation where they can cause self-harm. I mean, I don't know how much clearer it could be.
Thanks, Elizabeth. Dennis, I also want to circle back on, and then Brandon, I'm going to bring you in, and Lauren, appreciate you jumping in too. I'm just keeping notes here, and you mentioned obviously the conversation around the data that exists, I don't know if it's data that exists, but I'm wondering if there's data that exists around, you know, kids that have been restrained and you mentioned the injury piece. And so I just want to get clear on what data are you referencing there and how is that being, not from your perspective, but like, and then for the group to say, okay, how are we like considering that as it relates to the actual, you know, potential policy recommendations here. So I don't know if you want to do it now, but I just wanted to like put a ping in that because I'm curious to hear more about that.
First of all, like, restraint is not overused currently. So I don't know where people are saying, oh, the CDHS's stance is that it's overused. We analyze it constantly. We're not seeing an overuse or an inappropriate use of restraint as it stands now. So it's not true to say that CDHS is saying that restraint is overused. But I want to come back to
Who
like
said that? Sorry, I just want to make sure I'm understanding.
Pam, right?
I think I mentioned that, and not specifically saying CDHS said that, asking for the data, but there is a narrative out there nationally, right? Especially with the movements to stop the use of restraints. And so I think we need to not hold on to that national narrative. And if people are concerned with that, then my reference was we need to look at the data. So that's good that you're saying that, Dennis.
Outside of like very few outliers that are just outliers, the use of restraint in our facilities is being done pretty appropriately currently. So it's not necessarily a problem. So when you're saying, well, people are saying, well, restraint's not a trauma-informed intervention, that's not necessarily true. So like that's not my perspective on this. Like sometimes restraint is necessary, right? Now I also want to go back to the acuity of the children and youth. Yeah, yes, the acuity is more, but we looked at the run data. This group looked at the run data. Even with the acuity, the behavioral acuity of these youth, the runs are declining in Colorado. They're not going up, they're declining, right? So, I'm just thinking like that has to be part of the discussion when you're talking about whether or not like we need a physical intervention. Because like in Brandon's case, like I would far rather get to a place where we could say, and I've talked to Brandon about this. Like Brandon, if you locked your one gate, like what does that do for you? Does it reduce your run significantly?
I mean, yes, I agree with much of it. I mean, I really do. I think, and I don't mean to interrupt, but I don't disagree with you that we're talking about outliers and situations. And when you look at the overall, I think we're putting a lot of good practices in place to improve the services, and just seeing it from the 10 years I've been a director and what we've done. So I don't disagree with you, but I do think that there is this 5%. Everybody has the 5% of the population that this is a major issue and that is dangerous. And I think that's needs to be the focus as well, that just because runaways are going down and restraints are going down and things of that nature doesn't mean that it's still not kids in danger out there by doing this, because I do see that on a daily basis where there are kids that are prone to try to run and hurt themselves, and I want to try to protect it all, and I know that's not the best way to look at it from like a state perspective or a service perspective. You're looking at the total data, but I consider myself a practitioner and I don't want to see anybody get hurt to be honest with you. So I think we need to allow room for all encompassing approaches, and I think right now, unfortunately, physical intervention is a tool to stop that extreme behavior, and I think runaway is a behavior that is very unsafe for these kids.
Okay, so if that's the place that this group wants to get to, then because Elizabeth, with all due respect, you're saying imminent danger. That's not the threshold. It's imminent threat of bodily harm to self or others. You're looking at a statute change if that's what you want to get to. If you want to put in professional judgment, if you wanted to put in danger or risk, you're looking at a statute change.
Lauren, want to bring you in, and Brandon, I'm not sure if I know you raised your hand, so we can come back, and then Elizabeth, I see your hand up as well. Go ahead, Lauren.
Well, I know that the data just got shared, perhaps is the same data that Dennis is talking about, so we'll have to look at that more defined, but I did just want to ask, like, as that clarifying question that can get answered later, but is that data talking about total number of runs and restraints that have reduced, or is it a percentage of kids in congregate care? Just because if it is a total number, I just want to point out that the total number of kids in care has drastically reduced. I mean, even our space and being able to have 16 kids, we've limited to 9 from a pure workforce barrier. So I just want to acknowledge that I know it's in here, so I'll have to look at if it's percentage of kids in care versus total number, because that would be a very big differentiator. And then also just looking at the definition of what's being discussed today in this emergency space, because I do think there's in this risk and threat is just such a thin line of that interpretation. And I think that's where things get so tricky, and probably why this is such a debated topic, because it's so much of an interpretive space. But even in the definition, it says probable, which to me sounds just like risk. So if we're talking about a serious probable imminent threat, that still is, the same synonymous to risk, because we're still saying it's probable that this threat is there. I mean, I don't have an issue with the word being in there, but I just want to acknowledge that, it's such a thin differentiator, and it's all about how, and I know that, people will say, well, it just depends on how you word the situation or how you discuss it. But, and how nitpicky do we need to get in the in-betweens? Because again, if we're not seeing this being a massive issue currently right now, but to me, I just want to say in that definition, the word probable does insinuate risk to me.
Just on the data, we ran it both ways, aggregate and by percentage, and the numbers are just going down.
Which is great. Yeah.
Yeah, and I just wanted to well, actually, Elizabeth, was your hand still up? Sorry. Okay.
No, that was my question too, are the runs going down because they are taking fewer kids into care?
No, it's not that, well, there are fewer kids in care. So if you look at aggregate numbers, the numbers are going down, but we ran the data based on percentages as well, and the numbers are going down.
What about okay, Brandon, go ahead and jump in, and then
Yeah,
I
I just
ahead.
wanted to add around the harm and risk. I didn't read this, and this is for Stephanie because I know she loves case law stuff. But in Andrews versus People in Colorado, quote, the fact that the harm is not about to occur immediately is not to say the harm may not be imminent. Imminent danger is relative and not absolute, and is measured more by the nature of the consequences than the lapse of time. And that's what, again, going back to what Lauren was saying, I think this, it's not as simple as, saying that the, imminency of the bodily harm, it's about the likelihood of the probable, and that's how, and that's where you start getting into risk factors. And so that's where I think it's much more gray for facilities. Now, if we want it to be that there has to be immediate, right there in front of your face, bodily harm, then that's what the definition should say. But right now it doesn't, people aren't interpreting it the same way that Dennis is. I know I don't, and I think others don't as well. But I do know that there's a lot of people on Dennis that is interpreting that way, and I think that's the ultimate, conflict, and that's why it's been difficult to navigate this.
Like this is not Dennis saying this. This is CDHS's stance. It's always been the stance, at least since it's always been the stance, right? And also we have an informal legal opinion. That informal opinion would have looked at case law. Well, and the department is very likely to follow its own legal advice. So when we're saying this is what we say the line is, it's because we're following our own legal advice.
So, Dennis, what you're saying is we can't pick on you individually, only on CDHS as a whole. I'm just kidding.
You also have Renee here who has her hand up. Maybe she can pick on too.
Okay, perfect. And Renee, I see your hand up too. So I'm going to bring you in. I'm curious for you to jump in. I also just want to name, I'm seeing data shared there's, what would be helpful for me too is, Dennis, I know and I'm picking on you just because you're the latest one that said this around data provided. Can you make sure that you're sharing, if you have easy access, or if it's already being shared, that you can just reference exactly what data you're sharing? Because I think I'm getting lost on when you're like, there's data suggests XYZ. I just want to make sure that I'm understanding which data we're referencing.
I wasn't the one that brought up data, so I think it was Pam that brought up data. I don't have any data to reference.
I meant
And my
your,
question on that was just, do we have data? So we stick to data and not a national narrative that might be trending some of this, or misperception?
Right, but I think I've already like addressed that. Restraint is not being overused in Colorado. It is not being used inappropriately. I mean,
so there's two data
except
things
for there's outlaws, right? There's outliers, like where something does go wrong, but it's not being systemically. It's not going poorly.
the two pieces of data I think that I'm referencing are one, that runs have gone down, and two, that you had said that we have data around the harm of restraint. And so I want to know like how many kids are running where we're using restraint, and the data around you reference data on those two. So that's what I'm referencing when I say data.
There can't be any data on injuries to youth who run because we don't allow that to occur, right?
So then what are you referencing when you say?
So there, when there's restraint, sometimes there's injuries. That's what I was referencing. It
Okay.
does
Maybe,
happen.
Trace, if I could jump in, because I was sharing the data that we first discussed as a task force in 2023. So this is dated at this point because it only runs through February 2023.
Okay.
So for context for everyone, I just wanted to bring that back up because Dennis had mentioned we've looked at the data before. At this point, it's a year dated. And then I think, Dennis, what we were just curious is there updated data that would extend what's shown and what we shared almost a year, I guess more than a year ago at this point? And two, is there any way to cross-reference when a restraint is used to prevent a runaway, and if those restraints resulted in injury? I think that's what we were trying to get at. If we can correlate that data.
No, because it's just not allowed at this point. So I mean, you would get a very skewed perspective of it 0 or 1 or 2 because it's not allowed, right? So then if you ran that kind of data, it would show, wow, this is a really great intervention because it never happens. There's never an injury when a child tries to run from a facility, right? So no, I would be very shy of running that kind of data. Plus, I don't have a way to
That's what
do
we
it.
were trying to
I don't have
clarify. I think that was the interpretation to some folks. What you were saying is that the data is showing, and I just
No,
wanted
I never said anything about what the data is showing. That never was something that I asserted.
I know. I'm just trying to clarify because I'm seeing questions come up about what data we're talking about. So I'm just trying to clarify for the group what we have and what we don't have.
So we don't have data around when restraint. Yeah, because I think I'm in the same spot, Jordan. I'm looking at questions and thinking. So Dennis, not trying to hold the iron to the fire, just truly trying to get clear on like what do we have, what do we not have. So it sounds like there is not data for the reasons you just named around when restraint is used and if harm or if injury resulted in that restraint. Correct?
Well, we could do a hand count, but what would be the benefit of that? Because I'm already telling you that restraint is not overly utilized in Colorado and is not being used inappropriately. That CDHS is not asserting that it's being used like systemically. We're not asserting that restraint is being used inappropriately. So I don't know what we gain by that.
Yeah, I'm just asking just based on the comments that were made. Not evaluating if it would be useful or not. Stephanie, I see your hand up, so I'm going to bring you in. And then Ashley would love for you to jump in too. I know your question, so I just want to make sure we're bringing that in. Go ahead, Stephanie.
Is it okay to comment yet right now, Trace, or did you want to have a fuller panel discussion and questions? I just wanted to
Well,
know.
I mean, I actually like this. I think providers, if you're okay with it, I want to make sure one that we're giving you an opportunity to just kind of like hold court if you'd like. But I also think it's helpful to maybe hear from you all around as we're wrestling with this as a subcommittee, for you all to hear like what these questions that we do have, right? And for you to just jump in. So I kind of like that it's moving more towards a dialogue because I think that's really going to help us. But if y'all are like, hey, I've got something to say, everybody just pause. Happy to do that. So just send me a note. But Stephanie, we'd love for you to jump in. Then Renee, I saw your hand go down and now it's back up. So I'm gonna have Stephanie and then Renee, please jump in.
Yeah, I think that we have to come back to, this isn't a discussion about we're pro restraints or con restraints. That isn't the discussion to me. And data and numbers are irrelevant also to me at this point in this conversation, because as Brandon said, even if it's 5% of his total facility, which is a small number, or 2% or 1%, as long as we have 2 kids or 1 that may need to be restrained because they may cause harm to themselves or others right now, then the real issue is not data. The real question is, what do we have in place today, or what do we need to put in place for the future to consistently implement the restraint law as it is currently written, period, so that the state, all facilities in the state, staff in the state, are learning the same thing about the standard, how it should be applied, and all the number of gray areas and considerations that go into that in a similar way, right? To me, the bigger issue is, how do we get everybody on the same page, right? Facilities and licensing to say, yeah, we all have a joint idea of what this thing called restraint is, and we have a similar way in which we're going to analyze these things and apply them. That to me is the issue. Data, I mean, have it or not, it's not the question on the table for me. It's also just not the question for me about, it's not black and white. And I agree with you, Elizabeth. You know, we can't say, here's the 2 examples. One, somebody is suicidal, they've had multiple runs, that's obvious, you must do something. And the other is you live in a big field and there is wildlife. Come on. There's a lot of gray in between, and therein is where we're getting caught. And therein is the 5 cases a year or the 5 cases a month that we need to address. And I guess where I would like to know, Trace, is, do we have tools in place to ensure that we're all learning at the same pace and in the same way to consistently apply this law? I mean, that's the biggest question for me. And that's the question that I would like to know more about.
Stephanie, can I pause you there, and can we
Yeah.
ask that question and give our providers a chance around, as things are currently written, do you feel like there is a consistency? Can you restate that question? Because I think that's that's question number 1, because folks have kept bringing up training as a component here. And then I think there's also the question around the professional judgment piece and getting people's perspectives on, is that something that as a provider you feel like is missing? Because currently it's missing in written, right? And Dennis, your point earlier was like, if you change that, you're looking at a change statute. That is the conversation we're having, right? Is a potentially changed statute. So just want to say that's, that for providers, that is what folks are wrestling with, is there a need for change in the way that things are currently written, right? Based on this analysis.
Yeah, Trace, I agree. And just to put a finer point on it, what I want to know is there Colorado training around Colorado law and circumstances, right? That I know that you're all accredited through national organizations. I'm familiar with all that. But the reality is, I also know there's a variety of different trainings and a variety of different accreditations out there. And by the way, accreditation is still voluntary many times, right? It can be. So there are different levels. My only point is, what in Colorado are we doing to apply Colorado law consistently? The second thing I just wanted to address is to Dennis's point about statute change. Yeah, sometimes statutes have to be changed. I'm okay with that. And where I think our statute is vague is capturing some of this nuance. I mean, I would like to see other statutes and what they say about, because I've seen many other statutes like this that say, a restraint could be utilized, again, when there's an emergency, it's imminent, it's going to cause harm to self or others, using a professional or clinical assessment, or using best judgment, or being able to document facts after, right, or before. Like, these are the factors that a professional must consider when they determine if there's imminent harm and or risk to self and others. Like, there are statutes that lay out a bit more analysis about how people should interpret the law. This statute does not have that. So it isn't like a hocus pocus thing to think that we might want to put a little more specificity about the job to be done when applying the statute.
Thanks, Stephanie. Renee, I know you've had your hand up for a while, so I want to give you an opportunity. And then Marty, I'm guessing you're going to kick us off into part of those questions. But if not, I'll bring us back to this kind of these key questions I think that we're starting to coalesce around this training component. What exists currently? How does that feel for folks? And then also this potential, recommendation, what you would like to see a group like this consider around any sort of clarification in, like Stephanie was saying, like, do you believe from a provider perspective that would be beneficial for your ability to make calls as needed in situations? So Renee, go ahead, and then we'll go from there.
Yeah, I think I'm gonna hold it. I was actually gonna ask Dennis for some more clarification on something, but it's now we've moved on to kind of a different thread. So why don't I save that for later, and let's keep going with this conversation. So I've got the ball rolling.
Okay. All right. Thanks, Renee. We'll definitely come back. Marnie, did you want to respond to kind of Stephanie's point, or do you want us to?
I did, yes.
Yeah.
I really liked everything Stephanie said. I totally agree with it. Um, I think a few clarifying points for me are, I think the statute is written well, as long as we can, in our profession and in our expertise, can interpret it and apply it. I think that we wouldn't need a big statute change. I think it really does come down to interpretation. And I think that it's CDHS's onus to figure out if our interpretation met theirs, and it's ours to figure out if our interpretation of the law met our nationally recognized training. I think a lot of people in Colorado are CPI trained. I think most of us, I don't know, Brandon, I don't know if you guys are CPI trained, but I know a lot of us in Colorado are.
We're SCM.
Okay. I know probably the majority of people in Colorado are CPI trained. So I think that there is that kind of like, I think we're close to having a general training standard for Colorado. I think there are multiple issues that come to play, and one of them being location of our facilities. I think that I'm going to apply CPI much different than Pam might apply CPI at Shiloh facilities because of just location. And so for me, I really do think that Trace's point of saying, like, could further clarification and guidance and support of providers making those assessments and making that, honestly, I think the way it's written, it could, it really could lend itself to doing restraints at a time like Pam described or like Elizabeth described. I really do. I think that the statute as it's written could support us providers in doing a restraint on a youth that had significant history or there was an imminent threat at that moment. My issue, like one of the things that I want to help guide, and I was glad being here, is that I just hope that the policy recommendations don't force us into creating more imminent threat. Like at my facility, we've just always had a no follow. We do not pursue and we do not follow unless there are means to that threat. And so because we are on a very fast road where one of the directions you cannot see, they won't see our youth out in the road. We also sit on a river, and then we are not too far from a railroad track. So for us, it's there's a lot of imminent threats around us. So we will ascertain whether or not a youth is going near the imminent threat, and we won't create the imminent threat by pursuing them, because anytime we have pursued them, they will go to one of the more risky areas. So I have had staff refuse that policy in the past, and they have, in my opinion, placed a youth in more imminent threat. And so I've had to manage that in my capacity and with our staff and our training. So I just feel like it's written well. I feel like we
Marty?
are all trained. Go ahead.
And well, I was just gonna say, I'm hearing I'm kind of, and this is just me wrestling with like my own,
Mhm.
I'm kind of hearing two different things, to be honest. I'm hearing it's written
Okay.
well, and I'm also hearing that you would like there to be this professional, like you mentioned, the professional judgment piece. As the law is currently written, there is not that ability to make any sort of like, from my understanding, there's not any sort of um, best intent kind of like professional judgment. There
Correct. There's not a
Yeah.
best intent.
So I'm hearing you say that that would be beneficial, and I'm hearing you
Yes,
say that it's written well. Those two to me are conflicting
that's a great point.
because
Great
so
point.
yeah.
I
So
think
I
that
just want to
the,
clarify. So what you're saying is like
mhm,
for what it's currently written as, it feels clear for what it is, and
mhm,
there's a gap in the professional judgment piece.
mhm.
So is
So
that
then it just comes down to interpretation. And
right?
so then it's
Which
just,
which is why we're here because
yeah,
right
yeah.
because that's the challenge. So I'm just making, I'm not trying to pick on you. I'm
No, no,
saying
no,
like,
no. It's a
you
great
know,
point, and I appreciate it because I do think that there is a need for that, the professional judgment component to come
okay,
into play.
okay. Can we pause on that for a second? I'm curious, Pam, Lauren, and Brandon, from your perspective, is that something that would benefit you all's interpretation of what you can and can't do? Is this I just like, can we just get clear on your perspective of, would that be a beneficial potential recommendation from this group around, a potential statute change that includes something that's more explicit around professional, and I can't think of Stephanie, maybe there's a better language that you kind of referenced, but this professional judgment piece, whatever that might typically be reflected as in statute. I just know that you referenced like that is a thing in other statutes. Like, what is that language that we're talking about?
Yeah, I think it's really sort of an analysis or a balancing test, right? That is, and I'll have to find some other statutes that have just done this, but they would say, you can do X considering the following: the child's age, the child's level of education,
Right.
um, the child's physical and mental well-being. Like there are statutes crafted that provide considerations, and that's what law does. We shouldn't be guessing. And if we need to, you know, provide, it gives structure. It isn't rigid. It doesn't say, unless you meet the following 8 criteria, you may restrain, right? It's really about exercising all powers that you have, right? All considerations. A restraint may be possible when there's risk or when there's harm, blah, blah. I would have to go back and look, but I think we actually had some statutes somewhere that have a similar analysis. I need to find it.
Yeah.
George,
And in this group, we'll have to kind of go back and draft some of that. So let's say that we're operating from some language that is trying to get at this professional judgment piece. I'm going to call it that. And I just kind of want to keep us in this lane for a minute with folks of like, what are your thoughts on that? Would you see that as beneficial for the challenges that you're seeing kind of on the ground as a provider? So let's go Brandon, Pam, and then Marnie. And then Lauren, I'm going to pick on you too, just so we can go full circle.
Yeah, absolutely. I think anytime we can get in such a subjective field, when behavior is so subjective and mental health is subjective in a lot of cases, anytime we can get to the more descriptive, the more structure we get into place, I think is appropriate, and is best practice. And that's where I think evidence based is trying to get there with this in our science, but. The one thing I do want to add real quick, Trace, if we can, come back to at some point as well, is ultimately, I see all these issues, comes down to workforce. And when we look at workforce, right, it is a challenging field. And when we talk about risk and imminent harm and self, in this discussion, it has to be included also that, the layer about the caretaker that's, putting them in these individuals in these positions to be successful or not successful, or be in danger or not in danger. And in a lot of cases, when you look at a person-centered, a patient-centered approach, we're looking at the kid, and obviously that's the most important part, but you also look at that staff member that has to live with the consequences and the decisions that they are are doing. And it's not just about taking action, but it's also a lot of times inaction. And I hear a lot of individuals that are, that when bad things happen to kids, it ruins their life. It can't, they won't, these things are not in what they signed up for. And if we want to truly better the system, we need to raise the quality of caregivers that we have. And at this point, it's a depressed market for that. And you're not going to do that with general rules and when people feel unsafe in doing their jobs. And that's what you have in restraints right now. You have a scenario where professionals do not want to take on that risk because of the ambiguity of the direction that and the of being successful and what to do in these situations. So
Yeah, Brendan, I think it's obviously a really interesting and important conversation to be having. I appreciate that you're kind of letting us put that on the shelf for now. And I see this particular conversation around would this be helpful for providers and folks kind of on the ground as also being a part of the pie of the workforce piece, right? Of like, do people want a job where they feel like they're at constant liability, right? In your example that you're just giving, this would be something to kind of like this potential, recommendation would be something that would actually like support folks and feeling like they had that professional judgment and that this is a job that they would be excited to be doing. So I see that connection and going to put the kind of the broader workforce development conversation. I'm writing it down though because I'm like, when could we dive into that? So Pam, and then Marnie, and then Lauren, getting back to this kind of the crux of what we're saying around what are your thoughts on this professional judgment clarification piece? Obviously you haven't seen the written language that we might come up with based on the discussions, but just broadly, what are your thoughts?
I think clarification would be good, but there's a fine line, right? And we've talked about this in other regulatory meetings. If we define so closely, like Brandon said, this is human behavior. It's never going to encapsulate every single situation. It never will. And so there is the risk of defining too closely, right? It could lead you on an unintended consequence there. I appreciate what Brandon just brought up now, and was one of my points earlier. This is not just a provider issue, right? If we're just regulating and defining it for a provider, the provider is one piece of this child and family's life in this whole multifaceted um, environment they're in, right? I mean, and the provider gets the child when they're at crisis, especially the residential level, right? Kids and families are at huge crisis at that moment of time. And it always feels like the provider fix it. Nobody can fix mental health. Nothing is going to be cured in 3 or 6 months. If we're getting a 10-year-old or a 15-year-old, these behaviors have been happening and it's going to take time. So I just caution not fine tuning such a definition just towards the provider, because this is one piece of the whole pie that probably has 12 slices in it. And it needs to be integrated. And that speaks as a trained social worker, right? But also as somebody who is in this system. And so providers are one piece. And if we're narrowly defining on what needs to happen there, yes, there could be better accountability and some fixes, but we're going to continue this conversation every single year. I do agree with how can we get professional judgment a little bit more defined? But in some places it already is, right? It is in our curriculums. They're trained 5 days, and at Shiloh we train twice a year when it's only needed once a year, right? Kind of thing like that. But it comes back to how at the moment of assessing if it was right or wrong, like kind of the after effect, right? The consequence of it. So when there's an investigation, I think, is there a way we can fix that process a little bit more? So that professional judgment and that subjectivity of that staff in the moment of crisis is understood a little bit more, whether it's better writing of the account or what have you. And then going back again to Brandon's issue of workforce, that is key, because what we know is that the rates we get and who we can hire right, are severely impacting the workforce. We have Generation Z, right, that's coming up that no longer wants to stay at a job for 6 months, right? So we're constantly churning. I mean, this is just, our industry is going to have to change and do better with this new workforce, because the new workforce isn't going anywhere. It's just going to get, in 10 years, I think it's going to be 50% of our workforce population. And so how does that come into in play too? And what we know from science is that the prefrontal cortex is not fully developed till you're 25 or 26 years old. And we have always been such an underfunded system that typically we can only afford people who are fresh out of college who are interested in that. But it's such a mix match because they're not fully developed in their brain development. And yet we're putting them into a situation to have to work with these really traumatized children. And that to me has just been a system. I mean, we studied that at Columbia University 25 years ago, right? That's just a national system fix that hasn't changed. And there's a great international book that speaks to that too. So I'd love to share that as a resource.
Yeah, and Pam, I think a lot of the stuff you're kind of referencing to will be really helpful to circle back to when we get to this kind of training component piece around like what currently exists and what gaps do you see and what are those unique challenges to be considered, right? That you're referencing. So appreciate all those points. Marnie, I'm going to put you in the lane of this professional judgment piece. What are your thoughts on how that, what are the strengths of that? What are the challenges from your perspective? And then we'll go to Lauren and then Dennis. I want to kind of wrap this part of the conversation up with any kind of reactions you have from your perspective of challenges that you see, related to the conversation on this. So go ahead, Marnie.
Okay, I think the strength is, I'm going back to the same thing that I'm really struggling with, as long as we can assess, all of us in this field can assess imminent threat, that we should be covered as it's written. But I think that the interpretation issues are where the need to define it come in. But I do echo what Pam said. I wouldn't want to define it too, I wouldn't want it to be too broadly focused, because if it came to just age or just, I mean, there's so many different factors. I really would want it to focus on mental health. I'd want to look at like, what do our local center for mental health or our mental health centers that are doing the crisis evaluations and the mental health holds, what are they evaluating, and can we learn something from them that says this is what says a human, whether it's a child or an adult, needs to be detained for 72 hours. That is something that would really lead us to better defined rationale for when we're going to execute a restraint on a youth, and we're going to be assessing and applying that imminent threat. I think that's kind of where I would want to go, is let's take a look at what I don't know what their actual assessment looks like. Like, we usually have to step out of the hospital room when they're doing those assessments. And so I genuinely don't know. And I would recommend that we kind of take a look at that to see if we could ascertain some very clear guidelines of what we would be assessing professionally before we executed a restraint.
Thanks, Marty. Lauren?
I think the language about the professional assessment was helpful. It would be great. But yes, I think like Pam, I think mentioned this a little bit, but I think it can also create a little bit, if you get too nuanced into things, then it creates additional barriers for really either side. And so I just think that it gets complicated. I mean, I guess my interpretation of the verbiage as it is would insinuate professional judgment, but maybe other people don't interpret it that way. So it is needed. I don't know. Yeah, I don't know how people are interpreting it, but to me, I would have thought that that's what it was already stating without saying as much.
That's my struggle.
But yes, I mean, I know there's always space for interpretation, but then when, there's always, again, there's that fine line of like, now things are too defined. And how do you know when you've hit that really sweet spot where it benefits everybody, on all sides, the parents, the clients, the providers, the regulators. It's complicated, it's not a helpful answer, but
Yeah. And I appreciate y'all weighing in. The challenge here is there's clearly so many rich discussions that could come from this. And what we are talking about today specifically is this directive. And so I just want to I'm reminding myself too of like what we're really trying to get at with this subcommittee. And so I'm saying this also to our subcommittee members around questions that you're thinking of, and things that you want to know as it relates to how this might inform where you want things to go as far as any sort of recommendations, which is, and so I put it back into the chat, around, again, we're analyzing the comprehensiveness and effectiveness of existing state laws, and existing state laws and regulations. So I think it's super helpful to hear you all's perspectives on these different unique challenges and the workforce piece and, all the different things that we're all wrestling with, because it's just going to help inform subcommittee members, I think, around, clearly there are some things that folks are wrestling with. So I just want to name that and just want to say I'm challenged right now because I'm like, okay, this is all super helpful. And I want to make sure that we're getting at what we are truly here to answer. Particularly as it relates to the subcommittee members. So just kind of reorienting us and around this directive. So Dennis, I want to just give you an opportunity to respond to the things you're hearing, the challenges that you're kind of wrestling with or thinking through from your perspective with CDHS. And then Renee, I see your hand go up too. So, and Dennis, I didn't see your hand go up. So I just want to make sure I'm inviting you in if you want.
That's fine. I think some of you think like that, like I'm just going to dig my heels in and be opposed to anything you're going to suggest. That's not true. Like, if you want to go this direction, okay, but it's going to take some statute change, right? At the end of the day, my crew, we're just like an enforcement mechanism, right? So I'm not here to dig my heels in or anything like that. And but I want to dispel this idea that we're also super rigid. So I'll give an example. So when Mount St. Vincent was operating, they were serving younger kids, like little kids, right? There was a certain place they would try to run from the facility where if they got over a fence, there was a steep drop off. And so the facility called the monitor out and said, "Hey, we got this problem. What can we do about this?" And the monitor basically worked with them and said, "Well, this is an imminent threat of bodily harm. If they go over this fence into that very steep drop off, they're going to get hurt. So you probably need to stop them before they get to the fence, right?" So I don't know that we've ever had like this very rigid position that I think we're being put into, like that people say we're being very rigid. I'm not sure that's true.
Renee, jump in, please.
Yeah, just a couple of brief comments on, the reacting to the conversation. I mean, I do agree a lot of it can be an interpretation, like, putting someone on a hold and, I've worked in other states as well, and in multiple jurisdictions, and there can be different interpretations of the same wording. And, Dennis was referring to a legal judgment that, I don't know the details of, I wasn't involved in that or legal opinion that the department received. And, sometimes, things can be reevaluated too. I heard, Dennis, your point about that may need to be a statute change if there is a desire for certain changes from all involved. But I also think that sometimes there can be a reevaluation of interpretation. So I think either way, like Dennis said, it's not that there's no room for change, but certainly hearing a lot of concerns about it feels overly strict to folks and that it's putting kids at risk, at least in terms of the way it feels like the message is coming through. So I think there are a couple of avenues to be looking at that again.
All right. Thanks, Renee. And then Brandon, I see your hand up. if you want to we needed to take a quick break. We're right at the halfway mark. Can I reorient a little bit around what has surfaced? How does that align to where we're trying to get as far as this conversation goes? And we're going to come back with, I think, some more pointed questions to continue the conversation, and task force members also going to bring you in a little bit more. So Brandon, if you want to jump in with any kind of closing thoughts in response to this conversation we're having, and then we'll take a quick break.
Yeah, I just want to say I agree with Dennis that I don't believe his team has been extremely rigid on this topic at all. I think it's more though than, again, I want to just emphasize, like, it's not from just their perspective and like accountability the providers are dealing with around this. When there's a, when you put your hands on kids, in restraints, you're talking to a lot of customers and a lot of stakeholders at the table. And when there's lack of clarity around, specifics of when this can happen, when you can happen. I mean, in any given time, I could be having stakeholders and customers frustrated that I let a kid run versus also a kid that we stop from running because they're have high risk that we deem, like, either way, because of the lack of like understanding and specificity around this, and interpretation, it becomes very difficult to navigate. And again, and I think my bigger concern is more of like providing clarity to our people, my staff, to do a better job around this scenario to protect kids. And that's where I want to see this, direction go, is really just, specificity. Like, what's the best way to teach our staff to how to be able to protect kids and keep kids protected from, ultimately, hurting ourselves, hurting themselves. And that'd be my goal.
Thanks for that, Brandon. Stephanie, do you want to jump in before we break?
Yeah, just quickly, I just wanted to, first of all, Dennis, I greatly respect you. So I hope that nothing I have said today has put you back on your heels in any way. And I appreciate your positions. I really do. I think I just want to support what Brandon said. I think, again, we have to remember it's not about what works for me. It's about what works for this community of providers, right? And so if what I hear you saying, Brandon, is in my community, right, in my facility, I would like greater clarity around the law and how one must apply it, right? I heard that from you, Pam. I hear, Marty, a different thing, which is fine. But I think that as long as we have questions lingering about the application of this law, then it is something that we have to discuss. And I would say, and I always say this in every policy conversation, let's not toss the idea out because, right, you only get to the right language by playing with the right language, right? As opposed to going, hey, it could just be too restrictive and too prohibitive, right? We don't know that, right? There's a lot of words in the dictionary and there's a lot of ways that the law has carved out instruction and guidance without prescriptive language. And I don't want us to lose sight of that before we've even tried.
All right, Stephanie, I really appreciate that. That is a great spot to press pause. We're gonna take a 15-minute break because it's a 3-hour meeting, y'all. So we're gonna come back at the 55. So I'm gonna pause the recording now and then. All right, y'all, gonna bring folks back. Thanks for giving me an extra 5 minutes. Trying to wrap my head around all the great discussion happening. Jenna, just in time. I don't know if how long you've been here, but thanks for being here.
No problem. I was on for a little bit of before the break, but not too much.
All right, cool. Well, thanks for jumping on. I know you have a lot going on. We'll wait for folks to come back on video just so I know that we're all here. I've got a couple of ideas on how to just kind of, we've got 45 minutes really left together with this group. I think just as a reminder, my job here is to keep us in the lane of what we're trying to get to. So I'm not trying to shut anything down. Honestly, you're opening a lot of additional questions. And I'm like, okay, this is super curious around where some of these conversations are happening elsewhere. So you're just kind of getting my brain turning. But thanks, Pam. I appreciate that vote of support. Sometimes I'm like, oh, my brain is it's maxed out right now. So two things. One, Marnie and Elizabeth, I think you're just having an interesting discussion. So I just want to bring that in real quick. And then second is I want to turn us to this kind of training piece. I think I'm hearing like kind of disparate pieces around like what training happens, what training doesn't happen, the consistency. So I just want to like squarely put that on the table of like, all right, from a training side, what is happening, what consistently is happening, what inconsistently is happening from a provider perspective. What would you like to see? Do you see value in more consistent training, et cetera? And obviously, Marnie, your point around like, well, we do this, and then Elizabeth saying, well, okay, that's fine, but we want some disclosure if that's the case. So I think we've got a really interesting conversation to get into around the training piece. But I want to open it up first. Marnie, your comment in the chat was, you know, we restrain train, but do not utilize restraints. And I just don't want a definition to make us restrain versus using our professional judgment, because your professional judgment in this case, I'm guessing, would be that you don't restrain. So, and then
Well,
Elizabeth,
that and there's certain things, there's certain guidelines you guys could give us or put into this policy recommendation that would create more imminent threat to the youth we serve due to certain things around our location.
that would expand the definition of what imminent threat is that what you're
Yeah,
saying?
so like Stephanie had mentioned, like, age or something like that. And so I was just saying, I wouldn't want, there are certain recommendations you guys could make that would actually increase our restraints, like
Gotcha.
from 0
Gotcha.
to
Like as it's
something.
currently written, you're like, okay, we don't use restraints, but
Hmm.
that was further spelled out, which I know has been okay.
Grace, also, I think it can speak for Third Way. They would completely agree with what Marnie's saying.
And can you? I just want to make sure I'm understanding.
They don't do restraints, so they would be opposed to any requirement saying you have to.
Okay, gotcha. All right, but yeah, Marnie, I'm hearing you on the definition side then too.
Yeah, I mean, we would restrain if we had to, like, we're all trained, like, if there was an imminent threat, we absolutely, would do that. But if we are too closely defined, if we're put into a corner, we would have to increase our restraints. Like,
Okay,
we'd have to be doing restraints.
gotcha. Okay, thanks, Marnie. Elizabeth, I would love just to give you an opportunity to kind of talk about the disclosure piece from a parent side, and or obviously that goes beyond just any sort of care that would go into any sort of caregiver that would be making a discretionary placement of a child. I just want to make sure I'm understanding fully what you're saying.
Well, I think, and this may be just information I didn't know to check in, but, Timmy was at Mount St. Vincent prior, and they did use restraints for him multiple times in different situations, not necessarily when he was running. And I didn't understand that, right, that, because they notified me every time there was an incident, right, that they would put him in a therapeutic hold or whatever, or put him in the locked door quiet room. And then they would notify me that he ran, and I didn't know that they weren't just going out there and, managing him back onto the property, right, when he was laying in the road and threatening suicide. I didn't understand that they weren't utilizing that same protocol that they were using for other incidents inside the grounds. And so when I placed him at a different facility, then who they definitely knew that he was a run risk, and there was no discussion at all around what their policies were for running. And so I just, went in thinking that all the facilities are alike and they're going to, manage my kid in the same way that they did prior. So I think it's very important to disclose, to make sure that parents or anybody placing a child knows that information up front.
Yeah, thanks, Elizabeth. Really appreciate that. I think that's an important call out, particularly as this group has talked about centering voice of those most impacted, right, by these different policies, and obviously, particularly in your case, what would it look like to have policies that reflect that sort of co-design with parents and ensuring that you all are brought along in that. So, appreciate you bringing us back to center on that. Stephanie, thanks for your call out too. I think it's an important just clarification. I'm just going to read it out loud for the record. I think that's helpful. Is that there, and Marty, I kind of hear what you're saying too, but I think it's important to just clarify that there wasn't a suggestion around requirement to restrain youth, just that there would be language suggestion that gives professionals that more clear discretion of when or when not, right? That they could use restraint. So just want to clarify that and appreciate you putting that in there, Stephanie. I think it's a good thing for us to kind of get clear on what people were and were not saying. Brandon, if you want to jump in real quick, and then I do want to get into this training conversation. I think that'll be a really interesting thing to kind of hear from you all on, and task force members too. Want you all to jump in on these, as we get into the training piece. What questions do you have? What around what you're curious about? Brandon and then Renee, and then we'll move into that.
Yeah, I just for Marnie's concerns, like, I mean, I don't think anything that at least I'm suggesting or discussing is going to take away or should take away the best practice of least restrictive. And when you look at least restrictive in every scenario, in every situation, that will, a lot of times not include restraint. So, as long as we continue to, focus on the best practices of, mental health, which is, least restrictive is a guiding practice. I mean, I think both can exist, I guess is what I'm saying. A more descriptive pattern or structure to, when to do these things, restraints, but also, making sure that we understand that as professionals, we still have to go by the least restrictive, principles.
Thanks, Brandon. Renee, you want to jump in there?
Yeah, I mean, on that point, I do agree. I don't think it would be a problem to have wording that, didn't put people at risk of having to restrain at times when they wouldn't otherwise. I actually wanted to just quickly go back and ask Dennis, since we are the kind of prevention group we mentioned earlier, that runs have gone down. And I'm wondering if your team, Dennis, has any thoughts about why that has happened. It's a slightly off topic, but if there's a quick answer or if you just haven't looked at it, I'd be curious.
We've analyzed it every different way that we can, and we don't have any good conclusions. Now, but my guess right now, this is a guess. I think we bottomed out, and we'll start to see runs increase again by percentage, right? I think that will happen. So I don't know. I don't have any good answers.
Capturing that question though, just broadly, because I think that's just for us to state also that the group is wondering that.
One of our theories was it was during COVID, like that you really started to see an accelerated decrease, but then it continued to decrease. So we just don't know.
Yeah, I appreciate that, Dennis.
Behaviors in ways that I think are hard to explain. So maybe it is some ongoing thing and will undulate.
All right, I'm gonna pivot us we've got 35 minutes left. I want to again appreciate you all just kind of wrestling with us around these very complex topics. Again, we know that this is not the first time many of you have engaged in this discussion. It won't be the last. And so just really appreciate folks being willing to have some dialogue where it's not super clear or super clean, and maybe we disagree with one another, but we're staying at the table, and I really appreciate that. So just a note there of gratitude. Shifting us into this kind of training piece that I keep kind of hearing come up as as a potential part of this sort of analysis, right, of the effectiveness piece. This question is for and we've gotten kind of a small enough group that I'm just going to keep us broad right now. We can see all the windows. I'm hearing some of you get training, some of you don't get specific training. I heard the CPI thing thrown out there, and some people are like, what's CPI? There's all these different pieces. So I want to just kind of hear from your perspective as a provider, as it relates to the conversation of restraint, what and recognizing the challenges you've already named around workforce, young folks, the revolving door, right? Like I hear all of that. What is the training component currently? The strengths of that, And if you want to, let's talk around like what is currently happening? Is there a consistency in training from provider perspective? And I also heard earlier folks talking about from the national perspective versus a Colorado specific training. I'm not quite sure, just for this not being my like field of expertise, I'm not quite sure what the difference would be there. Like how would a Colorado specific training? I'm guessing it would be more that the trainers were like people that you could easily more access as far as like the challenges that arise. But I want to just kind of hear from you all, like what's the current training landscape for you in this topic? And then is there agreement? Like somebody take a stab at like what this looks like for your facility, and then let's see where other folks are.
I would say, Dennis might be able to um, describe this better, but I would think that I'm going to make an assumption that there's the performance management unit now that goes out, and it's one more monitoring entity that we all have, that QRTPs have. And I would assume that because they're seeing all of us and they're really diving into our training and they're really diving into like there are specific things they're digging into, one of those being training. And having very clear guidelines for what we're supposed to be training our staff on. I would assume we're pretty close to each other for the most part. I think there's some outliers of I think there's there's a harder time of some of our specialized group facilities turning QRTPs, getting their training up to par. But, and then I know that Colorado has an academy that they're going to be launching as well for our staff that would really bring standardized training
Level
for us.
setting. Yes, I have heard about this. Dennis, you want to?
If you go to what Pam put in the chat, what she's saying is accurate. What we do, this is for the facilities that do restrain, there's a huge amount of consistency because they have to have one of those, they have to be trained by one of those organizations like CPI. That's what the rule requires. So there's a lot of consistency among our providers on how this is done.
So my question with that, Dennis, is it sounds like, just, and I'm pulling this out of Pam's comment, each national curriculum that provider picks. So what's the filter they're running through to pick the right? So it sounds like there's like a bank of trainers that are national, and I'm a provider, and based on like either like my population, my unique challenges or whatever, I'm picking a trainer that best suits kind of my particular needs around. And is it broader than just restrain? Is this kind of like I'm picking a provider, or sorry, I'm picking a trainer around, these 10 topics? I just want to
It's
understand.
broader than restraint. So just using CPI as an example, the vast majority of the training you're receiving is about de-escalation rather than the actual restraint itself.
Yep.
But I do want to be clear though that these types of trainings don't really focus on when they do have some focus of when it's appropriate to restrain, but like that's not the main thing. The main thing is de-escalate first, use every possible method to de-escalate. And then if you do go hands-on, this is what it needs to look like. That's kind of how those trainings work.
Okay.
So they're not really focusing on if in Brandon's case, well, this suicidal girl is gonna go over the fence and run away. Should he restrain the kid? Those models don't really address that.
Okay. Gotcha. Thanks for that. Pam and then Brandon.
Ditto to everything Dennis just said. So thank you, Dennis. Shiloh, over the years, I think in 20-year history that I've been there, has done CPI. When I had a stint at another agency, it was TCI, right? But they're again nationally recognized. And CPI is
Pam froze for me. Did she freeze for other folks? Okay. All right. I'm gonna Pam.
But as a provider, we need to tell this, right? And we've had, let's see, what are we doing? We're doing CPI. So it'll be first certified. You need an 8-hour day for initial training. And then we do a 4-hour recertification training every 6 months for staff. And again, the emphasis is on de-escalation. It does talk about how to go hands-on. And then Shiloh over the past year has changed our initial training overall. That encompasses this, but everything else too, our own de-escalation, our own kind of trauma-informed approach. We've gone from 1 week training to a 2 week training for staff, as we've just seen kind of the workforce change and what skill sets need to be. So providers can also kind of modify their overall onboarding training and curriculum as well, where de-escalation and restraint will be one component of that. And this, well, I have some updated data, but maybe that, we'll save that for another conversation, because restraints have gone down significantly. I just checked with my staff. Since January, we have 2 QRTPs. Only 1 child has needed a restraint process, which is drastically different. And we can, again, refer that to probably change in census. We've gone way down in census. So again, that's just a tickle point to talk about how many things come together when we talk about the use of restraints, but definitely seeing an emphasis on the lower census of kids.
Thanks, Pam. Brandon, and then Lauren, and then I'm gonna open it up.
Yeah, so we use Safe Crisis Management. It's JKM is the national organization. They heavily focus on, de-escalation, and then, the physical interventions that you can utilize that are safe for kids. I, my belief has always been that the area of gap in this world is, the antecedent components of this, the primary, what I would call primary intervention strategies of treatment communities, organizations, and professionals. And I think, when we talk about training, that focus of just how to communicate to kids that are at risk, but not necessarily in crisis yet, and helping to mitigate those antecedents. I think that's where I see a lot of the gaps in our industry, because you tend to get professionals talking at kids than talking to kids, if that makes sense. And they're at high risk for, triggers, and you can't manage every trigger, and so be able to talk to kids is important, and I think that's missing in a lot of cases, at least from what I've seen. So like what I would do, focusing on trainings, and I've been trying to search for it, but there isn't much out there to just how to communicate appropriately, and even more so nowadays with professionals that are coming in are struggling more and more how to connect and with people in general. And so it's a big challenge. The people that I see that are successful in not going to restraints are people that can connect and help mitigate those antecedents for these kids.
Thanks, Brandon. And I'm hearing the Lauren, I want to hear from you, and I want to also just I think the challenge of this conversation is like not getting into the should you use restraints or should you not, but more we're having a conversation around the effectiveness of the ability to make that to do that. What Jordan, help me out here. I'm like, I'm thinking of the effectiveness and analysis piece, and I just want to make sure that I'm keeping this out of the lane of like the discussion around should you or should you not, and more in this effectiveness piece.
Well, it's, we're not discussing restraints, yes or no, in those categories. What we're asking is, as the statute exists presently, is there adequate guidance for the use of restraints effectively to prevent or help to prevent children and youth running away? Like that's the directive. And so that's why Trace kind of keeps putting us in this lane here. And kind of why we're trying to get to this notion of training, because that's come up as a component of potentially what we should be considering in tandem with statutory language that we discussed before the break. So we're kind of building on the discussion we had earlier this morning to see if we can support that.
Thanks, Jordan, for letting me pick on you. I'm just Lauren, jump in, and then I see Dennis and Renee. And then I have a question, and then we're going to open it up for task force members too.
Yeah, I mean, I would say, yes, there's a baseline of what training everybody has to do per program and per who we are regulated by. There's still a lot of interpretation as to how we do that. I mean, even for example, so we use TCI for our crisis de-escalation, and it's a 32-hour initial training with 16 hours annual refresher. So it's a lot more in time, obviously, than like CPI. And there's a lot of, and I've done SCM at a previous residential as well, but the restraints themselves are all fairly similar, but the, encompassment of the rest of the training, and it doesn't, there's no specification of what you have to use or what criteria they have to meet. And I would say also what really is missing is criteria or consistency around how on the job training goes. Like, we have this requirement for you must cover these topics, but in a classroom setting, it's really pretty basic information. And what I've really seen is, depending on who you have in supervisory roles or training or mentoring roles, really depends on how good of a training that does and the impact that it has on how well the staff are doing. Because we are having to find people, that we're not able to pay enough to find highly qualified people that have this wonderful aura about themselves that calm everyone down, have this great impact, and you have to kind of do the best with what you can find, and depending on where your facilities impacts, also what range of personnel you can find. And so the training piece and that on the job and consistent on the job stuff is what I really feel like would benefit. And I think that's what part of CDHS is working to get better at, is like, what does this actually look like? Because yes, we're regulated on what do we teach in this classroom setting, but I don't know that really does a ton of wondrous impact on how our staff are actually doing on the floor and how it actually impacts the client's risks.
Thanks, Lauren. Dennis, and then Renee.
I would like to suggest we not muddy the waters with the training. Those training curriculums are pretty solid. I don't know that we have a problem with how facilities are trained to do restraint. So I would not like to say, well, we have this problem, we need to fix it. I don't think that problem exists. I mean, I'm not hearing from any of the providers that it appears to be a problem either.
Yeah, I mean, I think that's the question. I'd kind of come back to, I think, Brandon, I feel like you were one of the ones that were talking around, like, I'm kind of curious your reaction to that. I feel like I was hearing some
Yeah,
kind
no,
of,
I agree with Dennis. I mean, I think our model from when the incident begins and handling things is a good thing. I think, and I think Pam put it in the she said it better, and I'm not the best orator, but she said it better than me that de-escalation is even too late for an intervention. The real root is to address behavior through understanding the skill. Skill or lagging, which leads to behavior. Behavior management is just a last minute safety tool. And so, like, I think the gap of training is, that acknowledging, understanding that kids are being placed because they're already at risk, and a lot of times that crisis is internalized and you don't see it a lot of ways, and they're in crisis. And so being aware and being able to identify those cues and understanding when people are in crisis and what they're at risk, and how to mitigate those antecedents, and talk kids through that and build that therapeutic alliance with them. I think that's the missing piece, that it's very subjective. And I bet you if you asked every provider here, we all try to teach that in very different ways. And they're probably all piecemealed into like our own stuff, trying to, like, from multiple different things. I don't think I have at least not run across anything that's real consistent around applying that out in real settings with our professionals.
And Teresa, I could just jump in, because Dennis, I hear you, and I just wanted to remind kind of like the lanes we're going in right now. We're just asking what the lay of the land is presently, and then that'll help us build into the discussion of, as we potentially want to address the interpretation or the inconsistencies we talked about specific to Colorado law, earlier, can we train to that? So we're not necessarily questioning this baseline training. We're trying to get a general sense of what's required and what training looks like presently. We're not questioning that. We just needed that landscape of what does training look like right now? And if we need to add training or add clarification around that provision in the law, how would we do that best? So I just want to make sure it's clear. We're not necessarily contradicting the whole training that's coming in. If we decide to make a recommendation around the law that we discussed this morning, what will that training component look like?
I appreciate that clarification, and I agree with what you're saying.
Cool. Yeah, thanks for that, Jordan. Renee, jump in, and then I want to open it up to other folks for questions, things you're thinking through.
Yeah, I mean, just I think separating it out is important because I agree. I think that the training piece is not super relevant to the question we have at hand in terms of the, interpretation of when restraint is used. I mean, ultimately that would, come out in like kind of program policies, and but it's not going to be like a huge training thing. It's not what the training's focused on. I do think the training is a super important part to consider for the prevention group, but as folks are saying, it's the curriculum is probably not the issue at this point. Places have solid curriculum in place. I think Lauren's point is really important, but it's a super hard nut to crack, that it's all in implementation and supervision on the ground and the mentoring, and that's something that's very hard to regulate. Even it's not something you could craft in paper, and super important piece of keeping kids from getting escalated and preventing running. But I agree, that's just sort of that aspect of training is kind of different than the question about this restraint question we're talking about today.
Thanks, Renee. What other, there's been so much covered today. Obviously we have a lot of work on the back end to kind of make some sense around what we're hearing from you all, around, what you're interested in and what any sort of recommendations might look like as far as our committee members or, task force members go. But, are there other questions, or as we kind of wrestle with this as a group, I'm speaking specifically to our task force members, anything that you feel like you're still thinking about that hasn't been addressed as it relates to this directive that we're really wrestling with? I just kind of want to open it up to task force members. What questions do you have? What are you still wrestling with? We've got this, incredible wealth of knowledge here with our providers and with Dennis, and just want to make sure we're utilizing the best of their time. So any other additional questions from you all? Jordan, I'll pick on you one more time as it relates to kind of what we're getting at with this directive. Is there any sort of gap here? And I'm just thinking specifically around the, again, the directive that we are statutorily required to reply to here. Is there anything that we're missing from this discussion so that we can kind of wrap up this portion before we come back to the full group next time?
Yeah, I'll let Brandon go ahead of me and then I'll jump in, Trace.
Okay. Yeah. Oh, here. Sorry, Brandon. I didn't see your hand go up. Brandon, jump in, and then Jordan will come back to you.
Well, I guess my ultimate question is, are, I guess for the purpose of this task force, or like, what is our recommendation? I mean, are we recommending that we clarify the statute more? Or I guess, I mean, what's the agreed upon? I mean, we had a lot of discussion back and forth, and it's great discussion, because I think it's a complex, problem. But I think the purpose of this is be to, like, what are we recommending? I guess that'd be my question, because I'm not entirely certain where everybody is.
Yeah, and I think so. I think from a process perspective, what I'll say is that our team will look at the conversation that was had today, both from what providers said, in addition to what task force members were like interested in, and then melding those two together into some sort of, any sort of recommendation around, and also it doesn't always, not every directive ends in a recommendation. So I just want to name that too, right? It could be, and I'm not saying that that's not the case here, but like, it could be that in the report of this task force, we talk about, here was the directive and here was the conversation and here's some, next steps that this group is recommending. We also know that staying in the clouds is never helpful from a policy perspective, and as specific as we can be is always helpful. So I'll just say my first stab, and then Jordan, curious to hear from you too, is that there does seem to be some momentum around clarity needed. The first part of this conversation, and I think that there would be benefit in us taking a stab at what some of those clarifying language piece around around the imminent piece that just does a better job of putting some parameters around things. It sounds like that is something that I heard today, so I'll just throw that out there. And then I think the training piece, obviously, sounds like that folks are mostly saying that they feel good about the training that's currently provided, but I think there's a lot of conversation there. So I think from a process perspective, Brandon, what we would be doing is that we would be coming back to the full group and saying, here's what the group is really wrestling with, and kind of go from there with some drawn up language to respond to. But Jordan, jump in. I'm kind of all over the place.
Yeah, I think so. As a person who will be drafting for this group, and to make it very clear, we're not voting on anything today. We'll bring it back to the full group for review and discussion. 3 main buckets, if you will, is what I'm hearing that will potentially pull into some draft language. One definitely has to do with clarity in the law, under the very clear understanding from this discussion that we do not want to create additional requirements that would require additional restraints. Instead, how could we clarify in the law that and just a reminder here, this directive is very narrowly tailored to the circumstance of preventing children and youth from running away from care. It's in the directive. So we're not talking about restraints, anything outside of that in our recommendation. So how could we draft a recommendation? I have a few thoughts in my mind, but I would have to play with them to address that specifically in the law, to give and get at that professional capacity, that professional discretion that everyone has talked here. So off the top of my head, that's where I think I would like to focus our language when we come back. And I've heard you all very, very clear on what we don't want to dip into and what we actually feel like we do want. And just based for context for this whole group, we're doing this not just on this conversation, but these conversations for this group have gone back to November and March. This is a very long-standing conversation. We've done polls, and I'm very comfortable in just kind of noting, we do feel like there's different interpretations, and that's a clarity that we're trying to give. So that would be the first thing we address. The second bucket is this notion of training. So if we come in and we provide clarification, again, what needs to be done so that not only do we do that in the law, but in the implementation that Marnie has talked about, and Lauren, how do we put that into place so that everyone is getting the same information about whatever potentially we would put in the recommendation potentially into law. So that's how we'll do that third recommendation. And then the third bucket I'm hearing very clearly right now is this notion of disclosure. So to Elizabeth's point, if a facility has a certain policy around restraint or practice, what is that disclosure going to look like? Again, given where we're sitting right now, I would probably see just taking a swing at putting that into statute, but that's where we're sitting right now. So I don't know if that answers your question, Brandon. Nothing's permanent. We're bringing it back. It tends to help if I can go offline and put pen to paper a little bit, but I think it would be helpful for me right now if there are things in there that just are rubbing people the wrong way.
Yeah,
Sorry.
Brandon, between the two of us, is that crystal clear? More work to be done. More work to be done. Yeah. Stephanie, jump in.
Yeah, Brandon, can you say more? The question is the question I had in my brain as well. And I guess I just want to hear from you, what would a clarification look like, right? Because that's what I hear the debate going on in this group, right? We don't want it so prescriptive that it says we must restrain in the following 10 circumstances. I get that. Nobody's suggesting that. I also have heard, Brandon, and you and I go back on these conversations with providers. I want to say it's 4 years now. So it's a real issue, right? As I have heard it, not from one people, but probably 20 to 25. So you and I I think, share that history at some level. And so I guess I just want to ask you directly, what is it that we would clarify about the use of these restraints that would address what at least I have heard, which is it's gray. We all have very different interpretations of when we can apply these things, and discretion is a great thing, but it also can cause harm to children if we exercise it radically differently than one another, right? And it also can create liability. So can you speak to me directly about that?
Yeah, so to me, and speaking specifically to the runaways, I'd like to see an emphasis and clarity around, which professionals can drive the individuality of what's needed for that kid. I don't think there's a strong enough emphasis on, using the clinician to better give clarity for each individual as they come in. All right. I think there's some conflict there, and a lot, lack of understanding between, what's prescriptive, what's prescribing a restraint, and what's actually just giving, here's what it should, like, if this happens, and this is the direction, this is the best way to, trauma informed work with this kid in these scenarios. And I think that needs to be a little more clarified. I'd also like to see, a much clearer understanding between imminent risk, and imminent, safety, because I think part of what the interpretation does now is it takes the ability away from, the professional to actually intervene. So like a lot of, I look at it practically, like if a kid's in my care and I'm a staff out there, and they run away and I can't do anything, then what's the point of having that kid at my, under my care? Like so like, to me, you have to factor in, what is the safest and most appropriate time to intervene too, with the evidence showing that this kid's in crisis and is going to do what we know that they're going to do, the likelihood that they're going to do. Because I look at it as it's like a rubber band. If you just keep waiting and waiting and waiting, and let the rubber band pull back, it becomes a more dangerous situation. And I would argue that earlier intervention in these scenarios, when you know what's going to happen and you're reading the cues, the evidence, will actually reduce injuries and reduce kids injuries and staff injuries. And if you look at it in other professions, that's a lot of times when they talk about law enforcement and when they act in crisis, you don't wait until the person has the gun. You try to prevent them to get the gun. Like, I mean, like you're trying to stop things, before it gets too far and it gets more dangerous, because, crisis is chaotic, and the more deeper you get into the crisis, it becomes more difficult. I would also point out too that the scenario that we're talking about isn't really about that they're not getting physically restrained, because they are. Okay. Kid runs, somebody's 9 times out of 10, not all the time, stopping them. Okay. But right now it falls in law enforcement that is doing it. Somebody's physically grabbing them and stopping them, okay, from doing it. But this is now, they have all that in between time between exiting a facility and that law enforcement getting that kid and bringing him back. And I would want the trauma informed trained individuals to be the ones stopping the kid earlier. It also prevents all the stuff in between that, but by the time law enforcement gets them, because I believe you, and I've talked to kids that have been, that ran away, and then they're back now at my facility, and if you ask them, and all the bad stuff that happens to them in between by the time law enforcement, and you ask them what do you wish that person would have stopped you? And for all the crap that happened to you, they were like, yes, absolutely. Do you know what I mean? Now, if you ask a kid that didn't get away and they were stopped, should you have been restrained? They'll, a lot of times they'll say, no, I shouldn't have. But like, so like, I think, you know, the dangers of an at-risk, irrational, emotionally, you know, younger kid that can't handle themselves outside in the communities at the time, which is why they're getting placed in a lot of these places, is, you know, it's dangerous. It can be extremely dangerous and a lot of bad things, as we all know. So I guess my clarity is like, I believe that we have to look at this as a broader perspective rather than it just being, you know, that, you know, I'm waiting for the kid to jump off the cliff, or I'm waiting for the kid to, you know, run in front of their car. Why do we, you know, this kid has this pattern. We know these kids. We know their, you know, their history, and we know what they're going to do when they're that escalated. So let's trust the evidence that they're showing us. So let's trust that you know, you know, they're not rationally thinking right now. Let's, you know, and so they're not responding to verbal de-escalation. They're not responding, you know. And if you know, you wait. To me, the imminency is when the last safe opportunity that I can actually physically stop them before, you know, I'm not going to have a chance anymore. Does that make sense, Stephanie?
Yeah, it actually does. And Trace, can I take another minute, or
Yeah, you're good.
Thanks. No, Brandon, I appreciate it. And because I definitely, I want to understand. So let me ask you this. What I hear you saying, right, is the definition as it looks today, right, is you can act when there's a fire.
Yeah.
And you're saying, I want to act before there's a fire. I see all the shrubs on the ground. I see the gasoline can, right? I see that we haven't had rain for a couple weeks. I want to make sure I see that the catastrophe starting to happen here, and I want to do something before that.
Yes.
Is that the analogy?
Yes.
Or it may be? Okay.
Yes. Because that's the point of the professional science, in my opinion, is that because when you wait till the fire, there's more victims. There's more, it's more traumatic, it's more problematic. And I know that's getting down a, you know, a rabbit hole here. So I get it. But at some, you know, at some point, you know, are we, I don't know. I mean, at some point, are we about, you know, ultimately say, you know, protecting people, you know, to all of them, or are we just more interested in, you know, agendas? I guess is how I look at it. Is, you know, because of course nobody wants you know, kids to be restrained. Nobody wants kids to be in these situations at all, or at least I hope nobody does. And you know, but that's not the reality of life. I mean, it's just not. It's not the reality of the situations that we're serving. It's not the reality of the situations we're putting, you know, our professionals in. And I see it every single day. And if we truly want to make the system better, you know, I think we start there. That's just my opinion.
So I guess my remaining question is, what would you change about restraint law, if anything? And is that even the solution, right? Is there another mechanism or venue to address the dynamic that you're discussing, Brenton? And maybe that is a law change, maybe it's a new law, maybe it's no law change at all. I'm just trying to now bring what you're saying together with this directive that we have to look at our statute and say, is this statute effective? And I hear you saying it's not necessarily effective, except in this limited circumstance when there's the fire.
Well, I guess I would say that one, emergency, you know, we were all taught Psych 101. We all have taken it, you know, probably at some point. Like, you know, it's fight, flight, or freeze, and flight. I mean, kids are going to do one of three things when they are in crisis. They're going to fight, freeze, or flee. All right. So to say to me, first of all, that running away is not a high evidence probability of, because it's not like they're checking themselves out of a like a substance abuse treatment clinic. Like, it'd be different if a kid walked down to and say, you know what, I'm checking myself out. Like, you know, they're in a rational state of mind. I'm not going to restrain them for that. Like, you know what I'm saying? But you have a kid that literally just, you know, is a part of programming doing fine. And then all of a sudden, boom, they're so pissed off. And then they start walking out of the campus and start leaving. And then they're saying, you know, like, we're not supposed to talk. Like, what do we think's going to happen out there? It's not going to be good, like, for somebody out there. And more times than not, it's going to be the kid itself. But a lot of times it can be community members, and a lot of times it can be, you know, stakeholders, and a lot of times it can be our staff that are with them. And it is, you know, so I think first of all is making it clear and just following what, you know, the science itself is saying, that yeah, running away is a high level evidence of that a kid isn't, anybody's in crisis when there's, you know, evidence around it. So I'm not saying that should be the sole evidence, you know, to say to justify the restraint, but I think just everyone agreeing that, you know, running away is a crisis response, you know, in a lot of these cases. And then around imminency, like I said, I don't know that, you know, why wait until the rock is thrown at the person so an injury can occur? You know, if you're there, if the kid's going to go pick up that rock to throw, or anybody, you stop them. Like, I mean, I think that has to encompass that imminency has to encompass that. So don't wait until the victim occurs, whether it's the self victim or a victim to others. Like, let's stop it before, you know, because the evidence is showing me that's what's going to occur. And as long as we can describe the evidence, all right, there, the likelihood, the probable, I think, is which is in the law, okay, where the probable of this is going to happen is going to be there. But right now, that's not good enough. Like, I've had discussions with people over and over again that are on the other side of this fence saying that no, you got to actually wait until, like, what if they don't pick up the rock? Well, what if, you know, what if good? Like, I mean, it is all, you know, I can't say 100%, but if the kid is, you know, escalated and is flipping out, cussing, you know, and then his hand goes down to pick a rock, I'm pretty sure that's what's going to end up happening here. Is, you know, so I want to bank on that rather than waiting for, you know, people to get hurt. Does that make sense?
Yeah, it does. I'm just trying to think, it makes complete sense, and I'm just analytically struggling with the what comes from that concern, right? Anyway, I don't want to monopolize it. I'm sorry I have.
No, you're not monopolizing, but we are at time and the other group's waiting on us. So the good thing is the two of you are on the task force, so you'll be back for this conversation. So all right, let's I'm gonna, oh, thanks, Jordan. I was just about to drop that in. The link is back to go back to the main meeting. But first I just want to say thank you so much to the providers and panelists, to Pam, to Marnie, to Brandon, I believe our friend, she had to drop off, and to Dennis. Thank you so much for, again, just the vulnerability of jumping in and sharing your thoughts and your thinking and kind of pushing and pulling on one another. I really, really, really appreciate it. And you all are, of course, doing really incredible work, and we're just so grateful for you taking the time. I know you're busy, so this is a long time to give to us, and we're really, really grateful. And we will definitely be, you know, you'll see the work of this task force kind of culminate late September, and so really look forward to continuing conversations with you as this group continues to wrestle. So thank you again for your time. Really appreciate it, and do not expect you all to go back to the main room, but task force members, I'm asking that you do, because we do need to go back to close things out. So with that, thank you all. Click on the link that Jordan just shared if you're on the task force, and I'll see you back in the main room.
So Jordan, even though you asked if we'd be available till 11, we don't have to click back there?
Nope, you are free
Okay.
to go. Thank you, Marnie.
Thanks.
Brandon, you're struggling to figure it out too, how to get back there?
Yes. Do I just
Yeah, just click the join Zoom meeting link in the chat and it'll pop you over.
okay.
see that though.
You don't see it? I can drop it again.
All right,
Here you go.
all right, thank you.
No problem. To letting you go, Dennis.